Hi, I'm Bill Gradishar, Professor of Medicine and Chief of Hematology Oncology at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center in Chicago. There are a number of different newer ways of optimizing the effects of anti-hormonal therapy, certainly in the metastatic disease setting. So in other words, in patients that don't have early stage disease, but the disease has gone to another organ. If that patient has hormone-sensitive breast cancer, almost uniformly today, we combine anti-hormone therapy with what we refer to as targeted therapy. And one of the class of drugs that are very commonly combined with either aromatase inhibitors or, again, drugs like fulvestrant, which is another anti-estrogen-like drug, is the CDK4/6 inhibitors. And these are drugs that affect cells so that they aren't able to go through the cell cycle and divide. So that's a very desirable thing if you're talking about a cancer cell, to stop them in their tracks. So when you combine a CDK4/6 inhibitor with one of these anti-hormonal agents, it's been demonstrated that you markedly improve the effects of the anti-hormonal therapy administered alone. It's almost doubling the time until the disease progresses with adding these agents, which can be quite significant depending on how early they're used in the metastatic disease setting. Furthermore, in patients who have particular mutations, and again, how we determine that is either by sampling the tissue or perhaps looking at a blood sample using a sophisticated test, we can determine if there's a specific mutation present that allows for partnering an anti-hormone therapy with a different kind of targeted therapy. In this case, what we call a PI3 kinase mutation, and we use a drug called alpelisib, which has been shown to be effective in a fraction of patients. So these are strategies where targeted therapy enhances the effect of anti-hormonal therapy. With respect to how we make a premenopausal woman postmenopausal, one tact, of course, is to remove the ovaries, which of course is a permanent maneuver because you're not going to put the ovaries in. That woman is now postmenopausal. In contrast, we can do it medically, which is called ovarian suppression, by using drugs which are referred to as GnRH agonists, and they basically fool the communication between the brain and the ovaries so that the ovaries are no longer secreting estrogen. And you usually have to give these drugs for a couple of months. They're usually subcutaneous injections. And once they have their desired effect, which is to drive down the estrogen level, which can be determined by looking at hormone levels in the blood, then you can add the drugs that we would typically use in a postmenopausal woman, in other words, aromatase inhibitors. You can do all the same things that you would do in a postmenopausal woman once you know and are convinced she is indeed postmenopausal. About 20 years ago, the development of the aromatase inhibitors was the hot area. And there were three, and continue to be three, aromatase inhibitors that are available to clinicians, anastrozole or Arimidex, letrozole or Femara, exemestane or aromasin. And these drugs were evaluated in all the same ways in both patients with early stage and late stage disease. And quite frankly, they're equally effective in terms of either reducing the risk of the disease returning in the case of early stage disease, or equally effective in treating advanced disease. So I think it just becomes a preference of the clinician to use one over the other. They have similar side effect profiles, including the possibility of causing joint achiness and also some decrease in bone density. So there isn't really a clear best one, so to speak, either from efficacy or side effect standpoint. And that said, sometimes when we have patients who have side effects on one, we switch to the other, and we occasionally get surprised where a patient may benefit from the other without as many side effects. So even though the science would suggest they're very, very similar, sometimes in an individual patient, one turns out to be better tolerated than another.